Last week was a big week for our virtual training. We went through our dental radiographers didactic course where we went through the history, the science, the techniques, everything that you need to know to be a knowledgeable and skilled dental radiographer. In your clinical, you started learning to take radiographs on our lovely friend Dexter. And as we progress over the next several weeks, we will continue to take radiographs. Hopefully by the end of the course, you'll take at least 2 full mouth series, if not more, and possess the necessary skills to begin taking radiographs on your patient. If you're working in a dental office or you're interviewing or shadowing, you are in what we consider your training period. So by law, you can take radiographs on a patient right now, but it needs to be under supervision. So if you are in an office and your hygienist or the other assistant is willing to watch you take the radiographs, you can. You are within your training period. Now, once you graduate, until you have your dental radiographer's license in hand, you cannot legally be taking x-rays. So there'll be that little limbo time, and thankfully the state is really good about getting that license to you, usually within a day of you sending in your application. This way you can be getting hands-on right away. You don't have to wait till you graduate to start taking radiographs. I actually really highly suggest that you are starting to place them in a patient. And it's really nice to be in a clinical setting versus your educational setting, to be on real situations, and you can ask questions with your hygienist, your assistant, whoever is right there supervising you as you're taking these radiographs, and it gives you some real-time feedback. Working on a live patient, I feel, is way easier than working on Dexter. They're more cooperative, they save it down most of the time, with your goal being good x-rays. We should not become careless in the way that we take x-rays where it's just good enough. We want really good radiographs. We don't want the elongation, the cone cutting. We don't want the cord to get in the way of the image. We should be aiming for darn near perfection when it comes to these radiographs, because taking these, although they be medically necessary, we are still exposing a living being to radiation. There are associated risks anytime that we're working with radiation. The risk is significantly lower than it once was in the past when we're using our digital radiology, but it's not non-existent. It doesn't just not exist. So because it's digital, we shouldn't just take the x-ray and go, oh, it wasn't very good, I'll just take another one. It's just digital. That should never be our mindset. We should never go, oh, it's fine that it's a little elongated, it's a little foreshortened, there's a tiny cone cut. It may get us by in this particular scenario, but every time that we take x-rays, we should be looking how we can improve. What can be better with our skills? What did we do wrong to get there? Now, before we delve into some deeper radiology information, our surgical, all these other exciting things for this week, because this week is going to be filled with a lot of external training videos, ones that we can't create in our office because they're going to be showing dental surgeries. They're going to show you how dentures are made in the lab. These are all things that are going to be stuff that you'll be working on the routine, and aren't things that can be simulated. We can't simulate the extraction of a tooth or a jaw surgery of a patient, but they are things that we can learn, discuss, and prepare ourselves for when we encounter them in an office. Taking some time to review the information that we previously learned, let's start off with some clinical charting. Go ahead and pull out your clinical chart. Pause this if you need to grab it out, and we will go through and practice those again.
Charting practice for chapters 22 to 25. 1, 16, and 17 are all surgical extractions. Number 32, however, is a simple, 31 is a simple extraction, not 32. So 1, 16, 17 are all surgical extractions. Next, go ahead and chart number 2 as a crown. Number 3 as a root canal. Remember, RCT stands for root canal. 4 is a root canal with a crown, which is typically what you're going to see as far as treatment goes. For example, like on number 3, we wouldn't do just a root canal. We'd have to do at least a filling to go and seal off the pulp cavity. But let's say they were at the endodontist, they would do just the root canal and put in a temporary filling material. 5 is an MO. 6 is a distal lingual. 7 is a class 5 facial. 8, incisal-facial. 10, incisal-lingual. 12, MOL. 15, an occlusal-lingual. 16 and 17 have already been charted with their surgical extractions, so 18, an MOB. 19, an MOD, mesial occlusal distal. 21, an MOL. 22, an incisal facial lingual. 23, a root canal. 28, a root canal and a crown. 30, occlusal.
When dental materials are being designed and manufactured, the chemical engineers and other area specialists have to consider the purpose of the material they are creating and the environment it has to actually function in. Restorative materials have the ability to restore the function of the tooth, and going even further, aesthetic materials are used to recreate tooth structure but with an artistically pleasing appearance, like your composite restorations. Composite and amalgam fillings are both being placed into the same environment, making it absolutely necessary for them both to withstand the same wear and tear conditions. The human mouth can bite on the posterior teeth with a force of up to 170 pounds, meaning that both of these materials need to have the ability for the force and then the stress that it can cause, the distortion and strain that can be changed, to be minimal or non-existent altogether. And since the mouth's temperature can take drastic changes from extremely warm to quite cold, they need to make sure that they can withstand those changes also. If you think about it, think about the asphalt and how it expands and contracts with the changing seasons. The resulting potholes would be detrimental in a restored tooth if dental materials were to react the exact same way. Those potholes would essentially create micro leakage that can be really bad for a tooth in the long run. Micro leakage in dentistry refers to the tiny gaps or spaces that can develop between a dental restoration, like a filling or a crown, and the natural tooth structure that it meets up with. These tiny, minuscule openings allow for saliva, bacteria, food particles to seep down in and potentially lead to secondary decay, sensitivity, and just honestly compromise the longevity of that restoration. It can arise from improper bonding between the dental material and the tooth surface, it not being prepared properly, or the cleaning of the tooth before the restoration placement. There's a lot of inconsistencies that can happen with the application of adhesive agents, which could cause this micro leakage to occur. One factor of dental materials that the chemical engineer is going to have to consider is the viscosity of the material, which is the property of a liquid that allows it to not flow easily.
For example, maple syrup does not flow easily, making it a high viscous material. With composite, it can come in different viscosities, from a flowable that can easily flow over the tooth surface and come into contact with the small irregularities of the tooth. Whereas the composite we have been using in clinical is more oftenly a more viscous material, allowing us to create bulk structure more easily. And each serve a purpose in different situations, as your EFTA and your dentist will determine which one is a better fit for each scenario. Both of these forms are going to typically be a light cured material that is polymerized or cured using a blue wave spectrum light and will not harden without this. There are certain auto-cured materials like your amalgam that do not require this additional step of polymerization.
We're going to be mixing glass ionomer. Glass ionomer is an extremely versatile material. It can be utilized not only for a cement, but it can also be used as a restorative material, and it can be used as a sealant. Now, why we like to utilize it in all these different manners is because of its unique property of releasing fluoride. You will have to mix this on the state certification exam, so it is important that you understand how to do this and then ultimately are able to perform the skill also. Any product that you purchase will come with instructions, so you're going to want to make sure that you mix this based on your manufacturer's instructions and that you always utilize the scoop that comes with the product. You'll also want to make sure that you have matching powder and liquid products. That way that's mixing properly also. So what we'll need is 1 level scoop of the powder. Always make sure that you recap your powders just to ensure that nothing contaminates them, and then also so you don't accidentally knock them over and spill it all over the place. So we have our 1 leveled scoop of the powder. Now we're going to take 2 drops of the liquid. Anytime that you drop liquid, you are not going to drop them horizontally. You will not get an accurate measurement. So what you'll want to do is make sure it's completely upside down. Now this is kind of thick, almost like a syrupy kind of liquid here, and I'm going to squeeze out 2 drops. 1, 2, right next to my powder. Now we're mixing this as though we're mixing a cement, so it's a 1-to-2 ratio, and then I'm going to take all of that powder and bring it right to the liquid. And I'm going to use this back and forth motion, incorporating all of the powder, kind of gathering it back up. And you should be able to mix this in a minute or less with minimal to no excess powder on the sides. The final mixing consistency that you're going to want is a tacky strand. So it's a really glossy look to it, and if you were to string it up from the mixing pad itself, it kind of strings out. It kind of reminds me of stringy pizza cheese, so that's kind of the consistency I'm looking for. This is what we're going to want to have nice and mixed for our cements. Always make sure that you clean your spatulas immediately after use. That way it does not harden on the spatula itself.
Just like glass ionomer is quite versatile, temporary restorative material can also be quite versatile, like our zinc oxide and eugenol. It can be used as a base, which is going to help build up the bulk of a tooth, or a temporary restorative material to reduce the sensitivity of a tooth to help us to determine its diagnosis while maintaining the tooth's function until a permanent restoration can be placed. Like in the case of going to an endodontist, they're going to perform the root canal, but they're going to place in a temporary restorative material. That patient then returns to their general dentist anywhere from 2 to 3 weeks afterwards to have that temporary restorative material removed a permanent restorative material placed back in, like a composite, amalgam, or build-up material if they're preparing the tooth for a crown, which is generally the recommended route of treatment following endodontic treatment. Today we're going to be mixing a type of an intermediate restorative material called ZOE, zinc oxide and eugenol. Now the liquid itself has this very distinct scent to it, and it's because of the sedative additive property in it of oil of cloves. The oil of cloves helps to sedate and calm down an irritated pulp. This can be utilized as a base, so placed in the deepest part of a really deep cavity preparation. It can be used as a temporary filling, for example, after endodontic treatment, or if we're trying to evaluate the longevity of a tooth, whether or not it's worth restoring permanently, or we're going to have to maybe do a root canal or extract it. We can also use this as a temporary cement. So this is a very versatile material. Just like any other material, you're going to want to make sure that your liquid and your powder match, that you have the correct scoop that came with the product, and that you've read the manufacturer's instructions on how to mix this. This also is on the state exam, so you'll have to be able to mix the ZOE. We're going to want a scoop of the powder. Now this isn't a completely level scoop, but you don't need a ton of extra powder, just a little bit, just in case your drops are a little bit big. This is a 1-to-1 ratio, so I'm going to uncap this. I'm going to get my eye droplet ready and put my drop right next to it. Mix this on a parchment paper pad rather than a smooth paper pad, and you're going to start by splitting the powder and bringing it to the liquid. The final ratio that you're going to want of this is a non-tacky ball. So you should be able to take this material and roll it in your fingers without it sticking to it, almost like how Play-Doh is non-tacky. But I can tell this is still really shiny, and if I tried to do that right now, it would stick all over my gloves. So I'm just kind of slowly incorporating that until I get to that chalky final look that I like. You may or may not use all of your powder here. If it is almost to the consistency that you want, but you still think it might stick to your fingers, then you could always, if you had extra powder, dab your fingers in it, almost like you do a rolling pin when you're baking. That way it doesn't stick completely to your gloves. But I'm gonna gather this all up. And I'm gonna get this rolled into that non-tacky ball that they're gonna want. So we can use this as a temporary cement, a temporary filling. I can also use this as a base in a really deep filling. All beneficial because of that oil of cloves that helps to sedate it. Whether you're using composite, glass ionomer, or ZOA as a restorative material, if a cavity were to go deeper than expected but does not penetrate the pulp cavity, it might be beneficial to go ahead and add additional layers to that cavity preparation. The layers that you would add is starting with a liner like calcium hydroxide, which is placed only at the deepest portion of the preparation to help prepare pulpal protection and help the dentin to regenerate in those areas, creating what we call secondary dentin. They typically come in a 2-paste base and catalyst mix that you mix together at equal portions, or a light cured material. Next, you would add in a base like ZOE that has that eugenol that can be very soothing and sedating to the pulp, and then sealed off with a varnish like Copalite. There are many techniques in the world of restorative dentistry, and these just begin to scratch the surface. One of the many roles of a dental assistant is to be able to mix up these different dental materials and know when they should be used within the procedure. Being familiar with the procedure is going to allow you to anticipate your dentist's needs. Think of it like learning to dance.
When you start dancing with a new dance partner, you're probably going to step on each other's toes a few times, but eventually you guys will be dancing in sync and be thinking like one person. That's why when you go out and you shadow or you interview and you see these well-experienced dental assistants as though they were thinking for the dentist, they didn't do that overnight. It takes some time working with your doctor, learning their preferences so that you can anticipate their needs and work alongside them harmoniously. Setting up all materials is a part of knowing what the procedure is and what is required for that procedure to be performed properly. Providing moisture control through the HVE, the high volume evacuator, and the saliva ejector, the placement of different isolation techniques like the cotton rolls and dry angles can all help you with your day-to-day roles as a dental assistant. Legal expanded functions need to be followed and adhered to a T. Even though that your dentist, you are under their supervision, they are legally liable for the things that you do in the practice. You can also be held legally liable if you were to perform a job function you aren't allowed to do. Just because I've seen an extraction a bunch of times does not mean I can do an extraction. Just because I've seen sealants placed a bunch of times does not mean that you can place sealants without first meeting the state requirements to do all of those job functions. In any of these procedures, infection control and patient comfort are two of the big things that you want to make sure that you're following any guidelines really well. If infection control is not on your top of your list of priorities, you not only risk breaking any kind of laws and mandates, but you also risk the safety of your patients, but ultimately your own and your families. If you aren't following infection control, you could be getting yourself contaminated or infected with something and bringing that home to your loved ones, which I'm assuming none of you really want to do. Patient comfort can be anywhere from reassuring words, making sure that you're having adequate moisture control so they don't feel like they're drowning, being gentle and not overly rough with our patient, knowing how to take radiographs and impressions on patients that say have tori will all help make the patient more comfortable and make them enjoy coming to the dentist, or at least a little less anxious about it. For our virtual training 7, we're going to review our radiology course, discuss what we must do to get our radiology license and maintain it, and then we will talk about prosthodontics and surgical procedures. In addition to a thorough review of our dental radiology course, we are also going to incorporate an extensive training course that was hosted by Henry Schein, all about 3D cone beam CT images. This is a very extensive course. It goes into training because you may be in an office where they are using this equipment, and this actually is teaching how to read and interpret. Although, again, this is not something that you as the assistant would be doing. You wouldn't be reading and interpreting it, but I do find it to be very informative, so you get an idea of how it works and what the purpose is behind taking such a in-depth image of the skull and jaw does for us in dentistry. We're not going to assess you on that, so don't feel overwhelmed because it is a lengthy course, and if you find yourself jumping through it to find some of the parts that are a little bit more intriguing, that's perfectly fine because, like I said, it is an extensive webinar series that Henry Schein hosted. It's It's really, really cool information. If we were to boil down the way that dental radiographs and x-rays are created is by taking an atom and displacing an electron. The electrons are what orbit around the nucleus of an atom. That's where the neutrons and the protons hang out. And that electron gets knocked out of orbit. And when it gets knocked out of orbit and when everything starts to reorganize and reshuffle itself, it creates a whole bunch of energy. Most of that energy, about 99% of it, is going to be lost to heat, and that 1% we're able to harness thanks to people like Otto Walkhoff and Wilhelm Conrad Röntgen, we can harness that energy to then create the radiographic image. So the X-ray is the energy that we use. The radiograph is the image that is produced by it. This has been around for quite some time, and as we go throughout history, you'll notice that the techniques and safety has greatly improved, and the technology that's available to us. One of the things that we're going to look at later is the CBCT scans, which is the cone beam imaging that gives us that 3D image that's great for planning out dental surgical procedures. This all happens inside the dental tube head. Inside the tube head that is filled with insulating oil to help keep this nice and cool because there's a whole bunch of heat that's created. You're going to have a vacuum sealed Pyrex glass tube. There will be two fixed points on either side of that tube head being charged either negatively like the cathode or positively like the anode. On the cathode, there's going to be that tungsten filament that as soon as you push your exposure button is going to generate those free electrons that then are attracted to the positively charged anode because those electrons have a negative charge and positive and negative are drawn to each other. And because that anode is fixed, it's not going to come to the electrons are going to be attracted to it. On the anode, there is going to be a little target made of tungsten that those electrons are going to come and smack against, and that's where on the atoms we're knocking loose electrons. And because the anode is tilted towards the actual cone or PID, the position indicating device, it's going to direct those x-rays out. But we don't want all of those x-rays exiting the tube head. Some of them aren't going to be beneficial. So they go first through your aluminum disc. These are your filters that will filter out the weaker wavelengths. The weaker the wavelength, the less likely it's actually going to be able to make its way through all of the tissues that it needs to create a good, useful radiograph. So we are going to want the stronger wavelengths to come out. But we don't want those strong wavelengths to come out and just spray the whole side of the patient's face. We're going to essentially funnel it and make it into a smaller centralized beam passing through the lead collimator. The PID, the position indicating device, is just that. It's indicating the position in which the x-rays are going to exit. What a lot of new dental assistants will do is they'll take an x-ray and they'll come in and there's nothing on the screen. And they're completely confused because the machine definitely emitted radiation. They could hear it, they could see it on the exposure control panel, but there's no picture. So you have to go through a series of self-checks and balances to figure out what happened. And as a new assistant, it almost always is that you never move that tube head off the wall. So make sure that you line the tube head up to the patient's face before you exit the room. If that's not the problem, then maybe you put your sensor in backwards. Maybe you never turned on your software, something's not. And with all of the different equipment that's out there, You may go into an office and they're using an x-ray software that you're not familiar with. So if they can take the time to train you on it, but also don't be afraid to jump on the interwebs. Like if you're on YouTube or the software's website, a lot of times different softwares have training webinars on their YouTube channel, like Dexis, Open Dental. They have a lot of training videos that are available to you free. And I suggest, to make yourself a better assistant and feel more confident in what you're doing, go ahead and find that stuff and do the extra homework on your lunch break. Do it while you're at home and you would regularly be scrolling or binging on your new favorite show. Take that time to polish yourself as a new assistant. Not plugged in properly. There can be a lot of reasons why that image did not get created.
Different pieces of hardware and software available to the dental professional, but Dexis is probably one of the more well-known names, and they have a variety of available products to the dental office, such as their digital sensors, their intraoral cameras, and their specialized product called the CariView. And so some of these videos and different things will walk us through, and so you can see the different products this particular brand utilizes, but there definitely are a lot more than just this.
This training video will demonstrate just how easy it is to take an intraoral x-ray with Dexis. Once you have your patient selected and have opened your DexRay screen, click on the X-ray capture icon in the upper right corner, causing the intraoral x-ray screen to open. You will notice that it resembles a tooth chart. To take a single x-ray, begin by selecting the tooth you would like to take an x-ray of by clicking on it. Wait for the green bars to appear, which will allow you to capture an image. Now place the sensor in the patient's mouth. Point your x-ray cone at the sensor and trigger the x-ray unit. When complete, your x-ray will appear enlarged on the screen. Click the X in the upper right corner of the x-ray image to reduce its size. To take a series of x-rays, click on the x-ray capture icon again and select the series. Notice that several teeth are highlighted in this selection. Position the sensor in the area of the highlighted teeth, position your x-ray cone, and trigger your x-ray. The software will automatically advance to the next set of teeth in the series, allowing you to take the next image. Place the sensor and continue as before. You'll have the option to go back and repeat an x-ray by clicking back, or advance in the next x-ray by clicking on next. Once complete, DexRay will mount, number, and date all your images. Congratulations! You have just taken your first x-rays using Dexis. This concludes the training session on acquiring an intraoral x-ray. This tutorial will highlight some of the general features of Dexis to familiarize you with the look and feel of the Dexis software. When viewing the DexRay or DexImage intraoral screen, you will know the orientation or view of your patient's images by the tooth numbers located in the center of the screen. This example indicates that teeth 1 through 8 are located in the upper left quadrant of the screen. The Dexis toolbar contains icons that, when clicked upon, will open the corresponding module or perform the corresponding task. When you hover the mouse cursor over any icon, a tooltip bubble will appear, describing the icon's function. The colors of the icons are green and gold. Green indicates the icon is inactive, and gold indicates the icon is active. By utilizing this color feature, you'll know which screen or module you're running and what functions you can or cannot perform. Under each icon, you may notice a green light or highlight. This indicates that there are images associated with this particular Dexis module or function. By clicking on the DEXIS logo, you will open a window which will display the program information and give you the option to access the on-screen manual by clicking on the Help function. When the Help button is clicked, an associated question mark will appear on the cursor. When you click on the area that you would like help with or have a question about, the DEXIS manual will open to that corresponding page. Once the manual is opened, you can then navigate through it by utilizing the index located in the left margin. The option to use the right click is also available from this screen. When you right click, you are given the ability to access many DEXIS functions, which correspond with the functions on the toolbar. The buttons at the far right corner are similar to the Windows functions of minimize, maximize, and close. You may also close the DEXIS screen by clicking on the X icon on the toolbar. This concludes the training overview of the patient screen. Welcome to a continuation of our overview of the DEXIS toolbar. In this tutorial, we will learn about magnification, spotlight, measurement, image text, and enhancement tools. Each one of these tools and functions can apply to images in both DexRay and DexImage modules, as well as images in the presentation panel. This is just an overview presentation, and you will find detailed descriptions in the DEXIS manual or from your on-site training session. The magnification or zoom function is applied when you select an image and click on the magnification lens icon or by depressing the zoom shortcut key, Z. Now move to the image and click any area of the image you would like to see magnified. A separate window will appear with the magnified area, and you can move to a different area of the image to see the area magnified as well. The spotlight feature allows you to scroll over an area of the image with a magnifying lens cursor to see that area in full contrast. You can move to other areas of the image in full contrast as well. The measurement tool allows you to easily measure distance from a starting point to an end point. You may also measure angle and density very easily. Calibration is necessary for more precise and accurate measurement. Image notes will allow you to write a note on an image, create an alert, or add an area of concern by drawing or pointing it out with the line polygon. Enhancement will allow you to apply a variety of filters to an image to enable better diagnosis, such as invert, colorization, clear view, darker, and relief. This concludes part 2 of the toolbar overview.
I'm Jeannie and I'm a DEXIS instructor, and today I'm here to explain how to use the CaryView caries detection device. It's made by DEXIS. It's great, new, innovative, patented technology, and what it helps us do is diagnose caries at an early stage. Transillumination is a non-X-ray near-infrared light, and what the device does is it shines through healthy tissue. That means if there's caries or decay, the tooth is porous, and so it's detected as a dark surface on the image itself so that you can see the difference between light and dark, just like you would in an X-ray. It comes with a holder, which is great, that you can position anywhere. When you take it out of the holder, it turns on,
There's two little lights at the end, which will end up cradling the tooth from the buccal and the lingual surface. It's really lightweight, which is great. It has a finger grip here at the end, which if you click it once, it'll freeze the image. And then if you hold it down for 3 seconds, it'll save the image. And then it also has two arrow buttons here to allow you to number the teeth. So from a clinician standpoint, when I'm working on a patient, I can easily navigate to number my images. You could also use the monitor and the mouse too. So if a doctor picked up the camera and he was in an awkward situation, the assistant could easily just grab the mouse and click it on screen. It also has two size tips. If you pull this off, this is the actual device here, and then it has two tips, a large and a small. The difference is the length of the arm. So depending on the height of the tooth, you could use a small or a large. The best way that I found to use the CariView is if a patient's experiencing sensitivity, or during my exam if I've seen that there might be a possibility for caries, that's when I really like to pull this out. The patient is experiencing some sensitivity on the upper left. So what I'm going to do today is I'm going to take an image to show you. Once I remove the CariView, I'm going to go to the computer. I'm in Dexis. I'm going to go ahead and click on the CariView icon in the upper right-hand corner. And it's asking me to select a tooth. I'm going to go ahead and click on number 14, and you can see automatically that it's going to bring up any other images I might have with tooth number 14. If I didn't know the tooth, I can wait until after my picture is taken and then number it. To capture the image, I'm going to cradle the tooth within these two arms here at the gingiva. You can see on my screen that it looks quite white. That could be an indication that my device is not fully seated at the gingiva. So I'm going to push it down just a little bit more. Just like that. Opposite, if it's too dark, I need to pull away a little bit from the gingiva. And that just depends on the length of the tooth. So as I push it down to the gingiva, you can see that in fact there is darkness towards the distal of that tooth. That is an indication of the near-infrared light not passing through, which indicates caries. I'm going to capture the image by squeezing the ring. To save the image, you would just squeeze the ring for 3 seconds. Once the image is at the bottom of the screen, then you know that you've saved the image. Squeeze the ring again and go to another tooth. One thing that I love to be able to do is educate my patient on what I'm seeing so that they understand the point of view that we're coming from when we're diagnosing something in the mouth. And what I love about Dexis and CariView is it automatically will bring up an x-ray, a photo, or previous CariView images for the specified tooth number. We can see if there's been any change since the patient was here last. It's a great way to be able to show them on the screen exactly where there could be caries. Once you're done using the CariView, all you need to do is remove the tip, place it in an autoclave bag, it's about 250 uses, 250
When you first turn on your unit, it will begin to calibrate the machine. Turn your unit on at the beginning of each day. Each patient should be treated as a unique case. So if we need to change the size of the patient, if the patient has all of their teeth or most of their teeth missing, we can change the kilovoltage peak or the kVp, which is the penetrating power. If we need to change what type of radiology technology we're using, whether it's film, digital, or they're using their hands to hold their film into place, which is pretty common if they have tori or unable to bite down. We can sometimes, as a last choice resort, use their finger of the patient to hold the film into place. You can also change what x-ray you are taking by turning the dial. On here, you've got your lower anteriors, your lower premolars, your lower molars, your upper anteriors, your upper premolars, your upper molars, your premolar bite wings, and your molar bite wings. When it's time to expose a radiograph, be sure to clear your room. Place your finger firmly on top of the exposure button. Press and hold until the tone completes and that light illuminates. You may immediately enter into the room and change your film or move your sensor to the next image.
In this video, we are going to go through the skill of mounting film radiographs. Even with digital radiology, it is important to know where things belong on the screen in the off chance maybe you've taken them out of order or you're just trying to identify what you're looking at. So when we're mounting our film radiographs and they come out of our auto processor, they are going to come out jumbled like a deck of cards that have fallen on the floor. Just like if you were to drop your deck of cards on the floor, you would first make sure that they are all face up. So to determine if they're face up on our films, we're gonna go one by one, not even worrying what's on the film. We're gonna go one by one and we're gonna feel for that raised bump. So there's gonna be a raised bump, so we always say pimple, not dimple, so you're gonna feel for that, and you're gonna make sure that that's raised up towards you on every single film. The reason that we do this is because if we don't, then we're looking at the film from the back side. And if we go based off of that, when we go to put it into the correct position in the mount, then things are going to be, well, a little out of order. So first things always to feel. Now when we were taking the x-rays, when we were exposing them, the trick for that raised bump was dot in the slot. That was to ensure that that dot didn't appear near the apex of a tooth. But for the purposes of mounting, the dot or the pimple should be raised up towards us so that we know we're looking at the front side, and it should not feel like a dimple. Once that's done, then you're gonna go through film by film and identify what type of x-ray do we have. It's like when you're doing a puzzle. You put the pieces with the edges in one pile and the ones without them in another pile, and you typically start with the edge pieces first because those are the easiest. So we're gonna start by making 3 piles. One pile is gonna be your anteriors, one is gonna be your posteriors, and the other one will be your bite wings. So that's the first question you ask yourself. Is this anterior, posterior, or bite wing? So a bite wing allows us to see the upper and lower teeth biting together with no apices visible. So this would be a bite wing. We'll put that in our bite wing pile. An anterior periapical will always be vertically oriented. Even though I'm holding this horizontally, so long side to side, you'll notice that the apex makes more sense if we turn it and orient it vertically. So this would be an anterior, plus it has vertical single-rooted teeth. Do you know what type of x-ray this would be? This one would be a bite wing. The teeth are biting together and there is no apex visible. What about this one? This one would also be your anterior because it was a vertical image. What about this one? This one's kind of new to what we're looking at. Now it does have teeth similar to what's in a bite wing, but look at the difference side by side. A posterior periapical has the apex visible, whereas a bite wing does not. Even though the teeth may be the same teeth, and they're going to be, the purpose of them vary. So this one would also be a posterior periapical. So you're going image by image, anterior, and making those 3 piles. I'm not even concerned, is it upper, lower, right, or left at this point? Posterior, because it's horizontal, and I can tell it's got those multi-rooted teeth in there. Posterior, posterior. So you do this every single film, anterior, posterior, or bite wing. This is posterior teeth, but you can see the upper and lower teeth biting together, so that must be a bite wing. Posterior, posterior. Here's another bite wing, so we can see the teeth biting together. And we're gonna go through, once we get our 3 piles organized, this is our anterior. We're gonna go through a single film at a time and figure out where does it belong in the mouth specifically, upper, lower, right, or left. But first thing we're doing is we're organizing our thought, basically. We're divvying up these piles to make it easier later. All right, that's the last of them. Now, really, you could start with any of those piles first. Some people like to start with the bite wings, but the problem with the bite wings are there's not as many clues. It's like starting with the inner portion of a puzzle. It can be done. It might take you a little while. You might make a few mistakes along the way, or you could start with the edge pieces and make it a little bit more simple. So I like to start with my posterior PAs first. That way I can look at the majority of the clues and determine where they go. I'm gonna hold one film up at a time so that my brain doesn't get overwhelmed, and I'm gonna look at this and I'm gonna go, is this upper or lower? So this is where we're pulling in our information and our understanding of anatomy of the mouth, where the maxillary teeth have 3 roots, or it may look like one fused root system. We can also look to see, are there sinuses? If you'll notice this white outline that's here in that film, that is a sinus cavity, and it's only gonna be visible in that premolar molar area of the maxillary arch. So right off the bat, I know this is maxillary. So what I want to do is turn it so that the roots are facing up like they would in the mouth. Then I want to determine which side of the midline does it make sense that it goes on. So looking at my mouth, my midline runs right down the center. So does it make sense for this to have it on this side of the midline, where my molars are closer to the midline, or on this side of the midline where my premolars are closer to the midline? So it's all about anatomy. We've got centrals, laterals, cuspids, premolars, and then molars as we work our way back. Now, determining whether this is a premolar or a molar shot in that area will be based off of what's visible. But because I can see a lot of the cuspid in this shot, I'm going to go ahead and assume this was going to be my premolar shot. Okay, so next step. Same questions. Is this upper or lower based off of the tooth anatomy? Well, it's hard to tell, but there really are 3 roots that are here. You have 2 buccal roots and 1 lingual root on these maxillary molars. So if you look really closely, you've got 1 root, 2 roots, and then that 3rd lingual root kind of extends up in there. But you also see that white outline tracing the root system, and that's your sinus cavity. So I'm gonna turn it again so those apices are facing up. And then I have to determine which side of the midline does it go on. Does it go here, where the molars are closer to the midline, or to the patient's right? Remember, on screen or on paper, if it's on the left side, it's really the patient's right. Now this makes sense because if you look, it matches the restorations that were in the previous film that we placed there. So we're gonna go ahead and slide that in. Now that is the molar shot in comparison to what's in there, because there is less of the cuspid visible in this shot than there is in here. Plus, if you'll notice on this second molar, there isn't a distal visible, but on this shot there is. Now there's no wisdom tooth in that shot. Next up, ask ourselves, upper or lower? You'll notice that 3 roots is a higher number than 2, so 3 roots is maxillary, whereas 2 roots are mandibular. So you'll notice there are 2 roots on this molar, so it must be lower. We're gonna go ahead and turn it so the roots face down. See the pattern here? We make our 3 piles, and then one film at a time we ask ourselves, upper, lower, right, or left? Do we have molars closer to the midline or premolars closer to the midline? We're gonna go ahead and put this in the premolar shot. We may find that we like another shot better. We just don't know yet because we're going picture by picture. We see that there's 2 roots, definitely some cone cutting there, but we can still see that there are 2 roots. So we're gonna turn this so that the roots are facing down and determine which side of the midline. Now, we can kind of play this matching game. If we look and tried to place it here, that doesn't make much sense because we notice that there's a molar missing in this shot and it's magically in this one. That doesn't happen. So it makes sense that we take it and put it over here where the premolars would be closer to midline. Upper or lower? Well, we're gonna say it's upper. We've got those 3 roots. We also can see the sinus cavities. We know that it can't go on the patient's right because that's already filled. So kind of process of elimination as we go. It's gonna go ahead and go in the patient's upper left. Upper or lower? That one's gonna be lower because it's got the 2 roots. Let's turn it and hey, it matches what's already over here. Now determining the difference between the 2, there's a very hairline difference between them. This one is still more posterior. Looking really, really closely, you can see just the rest of that distal root and it was cut off the apex there on the previous film. Now we kind of know that the last 2 are gonna go in one of those 2 spots, so it does get easier as we go. Is this upper or lower? Upper because it's got that sinus cavity, but looking at what's already in place in comparison to what I have in my hand, you'll notice that this one that I have is slightly more towards the front of the mouth because I can see more of the cuspid. That's this tooth here. So I will want to switch these around just by simply pulling them out of the sleeve and sliding them in. And then we know that the last must be our last mandibular one. Same thing here, kind of figured that this might be a little bit more of a posterior shot, but we were wrong. The one that we have now is, that's okay, just switch it around. So now we have all these posterior PAs in place. Now let's go ahead and go on to these anterior periapicals where they're vertical. Now these ones can be a little tricky, especially if they started using a size 1 film, which is typically a pediatric size, but on anteriors it tends to be a little bit easier to place, so don't be surprised if that's in there. And these will be always vertically oriented, so if you're holding it in this manner, that is incorrect. You're gonna wanna make sure that the roots are facing straight up and down. Now to know if it's maxillary versus mandibular, sometimes you can see the nasal cavities or some of the sinus cavities depending on how far back the shot is. You can also tell by the size of the teeth. So if we're comparing, your maxillary to your mandibular anteriors, there's a very distinct size difference between the 2. So let's look at those side by side. So these ones are your maxillary, these are mandibular. You can see that there's a big difference. Now we're basing it off of, is this more of a central shot or a cuspid shot? Well, 8 and 9 are, for the most part, right in the center, so we're gonna go ahead and slide that into place. We're gonna look at the next shot and we're gonna look and see, do we think this is upper and lower? Now, these are all single rooted, so it's not as simple as asking ourselves how many roots there are. We have to rely on our knowledge of other anatomy. So we can see that there is a slight bit of the sinus cavity visible there because this is kind of spaced really far back in the mouth for this shot in comparison to the central. You can also see that there are some composite fillings placed there that kind of match up with what's already there. So let's go ahead and spin that. But now we have to figure out, does it go on the patient's right or left? Again, you have to know anatomy. So when we're looking at these teeth, we can see that there's an incisal edge on those, comes to a point, and then that flat occlusal edge there. So it must go central, lateral, cuspid, bicuspids. So we're gonna slide it into the midline where it should be. Looking at this one here, and always making sure that you have that raised bump toward you, so you should always feel pimple, not dimple, when mounting. So these are really skinny, not very wide teeth. They don't match up with what's already in the maxillary, so these will be our mandibular. Looking at this one here, very skinny, smaller central incisors in that shot. They do not have any composite fillings like what's in the shots already. So we're gonna say that's a lower. And then determining where it goes in relation to the midline, we have our centrals, laterals, cuspids, and bicuspids. So we're going to go ahead and cite it in here. So as you get quicker at this, you're going to be able to just identify these. You don't even necessarily have to make the 3 piles as you go. This is mandibular, much smaller, no restorations visible. Has to go in here. You'll notice it's with the shape of the mouth. And last but not least must be our maxillary right cuspid shot. So now that we have the edges of the puzzle put in, we can fill in the inner portion of the puzzle, and it's so much easier. Since there are less clues to anatomy on these bite wings, then we can go through and match, missing teeth. We can match restorations. I know that this one looks like the restoration in this film. I can also look for the curvature of the bone. The bone is always going to curve up. On the lowers, we have the retromolar pad, and on the uppers, we have the maxillary tuberosity. So it's like your patient's always smiling. So if I know that, right now it kind of looks like it's starting to curve down just a bit, and this restoration doesn't match this area of the mouth, so it can't go there. So we're going to turn it. We're going to see if this matches. And it does. You're going to see the same teeth that are in the periapical shots visible in the bite wing shots, but that's because we're looking at the inner proximals now, so the teeth do need to bite together. All right, so let's take a look at that, see if you can identify where that should go. A little bit more light on it. So there's no missing molar. We know it can't go on this side of the mouth, so we're going to go ahead and spin it. Or keep it where it is. Actually, it's right where it needs to be. You can kind of see some of those root systems, so that helps when you can see some anatomy, that there's 2 roots. You know that must be on the lower rather than positioned like this, like it's an upper. This one's slightly more anterior. You can see the distal of the cuspid, whereas you cannot see that visible in this bite wing. Now we know that the rest must go on the other side, so we just match. We've got a missing tooth that's low on the lower. We can see that things are starting to curve up. So we're going to get those into place. And actually, I'm going to switch those because I like this one better as your molar shot. There's a slight difference between the two. You can see one is a little bit closer to the midline than the other. All right, so now that we have our full mouth series mounted correctly, let's take a look at some of this anatomy so that we really do understand what we're looking at. Let's start with the anterior periapicals. So we can see that we've got our central incisors right at the midline. We've got some composite fillings, so the material is a little bit more dense than the rest of the tooth structure. That's why it's radiopaque or lighter in appearance. You can see the pulp cavity running through that all the way to the apex. You've got your sinus cavities visible in the anteriors, but more visible here in those posterior PAs. These also have those restorations in these pictures, so they match up like a puzzle. We have our 2 roots on the mandibulars, so we've got those there, the bone curving up. We've got our skinny, longer, rectangular shaped rather than the boxy shaped incisors on the mandible. We've got those missing teeth that match. You can see the pulp cavity, so that radiolucent or that darker area where more radiation was able to pass through. So those are some of the things that we can look and see, and those are some key indicators of where these films need to go. So think of this like a puzzle and go through and piece it together. So whenever you see something that's lighter, it's radiopaque. It's more dense, less radiation was able to get through that area. For example, this film has crowns on the tooth and a root canal and some bone loss around the tooth too. That bone level should be significantly higher in this shot. So hopefully this helps you with your x-ray mounting. The key or the goal is for state certification, since this is one of those skills that you have to perform for that, is to be able to do this complete process in 5 minutes. So this is where it's really important to be practicing and getting that goal in mind and get faster as you go.
As a part of our review of the radiology course, let's practice interpreting radiographic errors. This is going to be interactive. What I'd like for you to do is when the image pops up on your screen, if you need the time, pause the video. Think through what is that error called, what caused it, and how might I fix it so it doesn't happen again. Let's start with an easy one. Take a moment, pause the video, and tell me, what is this called, what caused it, and how do you prevent this from happening again? What this error is called is a cone cut. And you can tell from that telltale moon white shape that is on the image there. This is a bite wing that they've cut off with cone cutting. What's caused this is improper placement of the PID. You don't have it centered on the tooth and your sensor, so it's cutting off a portion of your image. So being careful to line up the PID with the rings on the REN system is going to help make sure that you don't end up with this cone cut image. Our second X-ray error, what is it? What caused it? How do we fix it? This is a foreshortened image. A foreshortened image is when there is too much vertical angulation. Vertical is that up and down angulation, and on the maxillary ones, you're shooting like down into the mouth too much. So making sure that when you place that sensor into the patient's mouth, that it stays nice and parallel with the tooth, and that you line that tube up at the correct angle to match the pitch of the placement in the mouth. You can kind of visualize here that that tube head is shooting down into the mouth and not as parallel with the teeth as you would want it to be. And that's where you end up with that foreshortened image. What's the error called? What caused it? How do we prevent it? This one is essentially the opposite of foreshortened. This is an elongated image where it's stretched out because you have insufficient vertical angulation. You're shooting it at too flat of an angle for that particular part of the mouth. What you'll want to make sure that you do is that when the patient bites down, that it doesn't shift and tilt that sensor so it's no longer running parallel with the mouth. And then again, when you line that tube head up, making sure that it's angled at the same pitch that the REN system is. That we can sometimes put the sensor in the mouth correctly, but we don't position the tube head correctly. Thinking of it more like the horizon, we don't want our tube head usually right on the horizon for some of these images, especially those maxillary anteriors, because those teeth do tend to tilt a little bit, so it's going to adjust the angle of our tube head accordingly. If you see this error, then you want to make sure that you give yourself a little bit more angulation, either in the positive or negative direction, depending on whether or not you're working on a maxillary or a mandibular image. What is this panoramic error? What caused it? And how do we fix it? This is improper patient placement, so it looks like the patient is smiling. That occlusal plane should be completely flat across, not smiling up. This particular image is because the patient's chin is tilted down. You want their occlusal plane to be parallel with the floor. What I've always done with panoramics is once I get them in the machine and I feel like they're in a good placement, is I have them smile so that I can see their teeth and visualize that occlusal plane and making sure that it's nice and parallel with the floor, that it's not that their chin is down or in the opposite, that their chin is too high. You will be applying for your dental radiographer's license on your last day of class. The way that that works is that you have completed the virtual training. you have been working on your clinical training, and then you will get a certificate on the last day of class stating that you've met all of the requirements. You will then log into a portal on the state's website and apply directly there. You will pay the fees in class, so be prepared to pay your fees to the state that day so that you can get your radiographer's license. It typically takes about a day to get it, so if you're a weekend class, anticipate getting it on that following Monday, as long as it's not like a federal holiday where the state dental board would be closed. And then if you're a weekday, you can generally anticipate getting it the next day, and sometimes even that same day. You'll get an email with your radiology license. They do not send a physical copy. They will send you an email that says congratulations. It will have a PDF file attached to it, and that's what you can print and hang in your dental office. Your first renewal, if you are getting your license in an even year, you still have to renew by the end of that same year. If you're getting it in an odd year, you're not renewing until the following even year's December. If it's your first renewal, you'll get to use that same certificate that you're going to get on the last day, so keep hold of it because we're not going to keep track of a copy for you. You'll want to make sure that you keep a copy of that, probably in your student workbook, and you'll use that for your first renewal. For your second renewal, you will have to have 2 hours of continuing education. It can be an in-person course or an online course, but it needs to be a minimum of 2 hours in a topic related to dental radiology. You'll log back into that same portal, pay a fee, upload documentation that you've completed that renewal course, and then you'll be good to go for another 2 years.
Radiographer's license, you will go to elicense.ohio.gov. On the center of the screen, you will see a red button that says Login/Create Your Account. After you click on that, you will either go to the existing users if you already have another license with the state. So for example, if you happen to have a cosmetology license and it's recent, you applied online, this is where you would go. You'd log into that same account and apply for your new license here. But for most of our students, it's going to be, I don't have a license, and you're going to be signing up for a new one. If you happen to have a license that's older with the state, but you applied with like a paper application and you never signed into the e-license portal, you might be clicking on have a license, but most of you will be I don't have a license. After you click on that, it will ask for your personal information, your first name, social security number, birth date, all of that stuff. And once you've confirmed that, then what it'll do is it'll take you to your dashboard. Once you're on your dashboard, you will click apply for a new license. If you have any other previous licenses, you'll see them listed at the bottom of your dashboard. Apply for a new license, dental board, radiographer, and general application. It'll ask if you are eligible to receive it, so you must have completed the 7-hour radiographer course. Yes. And then save and continue. Since I already have this license, it's not going to allow me to go to the next step, but it will prompt you through the questions. You'll confirm additional information about you, like military status. It will ask you for a public and mailing address. You do need to input both of those and make sure you check the little checkbox and save as public and save as mailing. It will not actually show up as public. It will show up just what county that you live in when we look up your name. The other thing that you're going to be doing as you're going through those yes and no questions is you're going to get to a section that asks about your education, employment, and previous licenses. For most of you, you're going to skip that page. You are not going to put in the education as us. That would be if you were applying for, say, your dental license or hygiene license. They need to know what college that you attended so they can confirm that. You don't need to put that. The employer information is if you happen to already be employed by a dental office, you can put that information in there. But for most of us, we're going to skip that page. When you get to the section with the yes and no questions about your potential criminal history, anything like that, answer those honestly. If you do answer a yes, what they'll end up doing is requesting some court documentation from you just to confirm that it is a closed out case, but they will email you directly requesting that specific information. They'll close down your account to where you can't log back into it once you submit the application. And doesn't mean you're not going to get approved. It just simply means that they require additional documentation. So they'll send you an email. You'll respond to that email, sending them the documents that you need. Once you've gone through the full completion of the application, you will also submit a photograph of that 7-hour certificate, a photograph of your hepatitis B vaccine showing all the necessary dates, and then the photo, it's supposed to be a passport style photo. You don't actually need to go get a passport. Just stand in front of like a white or a gray background. A headshot where you're smiling is fine. No filters or anything like that in that photo. And then you submit it and you pay the online fee. That usually only takes a few hours for them to approve it. As long as it is done during business hours, you're more than likely going to get that approval sent back to you in email, or a denial if maybe something's missing or something's incorrect or not legible. They'll send that to your email. There are no paper versions of your license anymore. So what would happen is they're going to send you a digital version, a PDF that you'll print, and then it will also be available on the eLicense website. Your employer and you can verify your license by going to the license lookup button, and you can type in last name, first name. It might help you if you have a very common name to just filter it out by the board that you're looking for, but then you can find that information listed on there.
Prosthodontics is the area of dentistry that focuses in on dental prostheses like dentures, crowns, bridges, and was one of the 12 dental specialties recognized by the American Dental Association. The ADA defines it as the dental specialty pertaining to the diagnosis, treatment, rehabilitation, and maintenance of the oral function, comfort, and appearance of oral health for patients with conditions dating back to the 1700s with Pierre Fauchard discovering methods to replace lost teeth using things from carved ivory or bone, and also even introducing the idea and concept of dental braces to correct malaligned teeth. In 1974, Patricia Smathers Moulton became the first woman certified by the American Board of Prosthodontics. In 1994, Jane Brewer became the first female fellow in the Academy of Prosthodontics. In 2003, Nancy Arbery became the first female president of the American College of Prosthodontics. And in 2006, Jane Brewer became the first female president of the American Academy of Fixed Prosthodontics. There's a lot of women that are making strides in the area of prosthodontics. According to the American College of Prosthodontists, it is a dentist who specializes in the aesthetic restoration and replacement of teeth, receives 3 to 4 years of additional training after dental school, and restores optimal appearance and function to a patient's smile through the planning, surgical placement, and restoration of implants can also fall under the field of prosthodontics. Of missing or deficient teeth. It has only gotten better from there. In 1964, Jean Sinkford became the first female prosthodontist with her PhD degree. Crowns and bridges are what a lot of the patients most notably know the prosthodontist to treat for, but dentures are also included in there. So there will be some videos that are going to explain to us the differences between them. We'll get to see different fabrication occurring, and that way we can get a better understanding of what's going on in a lot of cases at the dental lab.
When you get a new Timp Crown material, you have to make sure that you bleed the material to make sure that it is coming out in the correct ratio. Otherwise, it can cause your material to not set up as designed. So to put your new material in, you're going to grab your gun and you're going to press on your release button, pull back. You're going to lift up the top part of your gun, insert matching the size tubes. See the holes? Make sure it's locked in. We're going to take off our cap that it gets shipped in. And we can grab like a 2x2 or just really anything to extrude the material onto. So we're going to squeeze until we see both materials start to come out. So that one was pretty quick and easy. And then we either put our shipping cap back on or our tip on, just making sure that we always have something on, otherwise this will set up with the air. We're going to take this little blue triangular cutout and we're going to match it up to that little triangular section there. Press in and twist to lock it into place so that's nice and snug, and then you can squeeze and use it. In the direct procedure that we've been working with, but it's used for, larger restorations if we were prepping for a 6-unit bridge or long-term provisionals where we're going to be keeping it on there for 3-4 months long. Those would be reasons why we would have them made by the lab tech. Now, when we're doing the direct technique, the provisional is directly produced in the patient's mouth using this anatomical impression that we're getting ahead of time. Usually alginates or some kind of alginate substitute, which we've used alginate, is used for this preliminary impression of the unprepared tooth. Now alginates, these are pretty accurate and they're less costly than it, but the disadvantage is that they have a poor long-term storage stability because they do dry out, they shrink, they aren't going to be able to be used for the same amount of time that you would see the alginate. Alginate substitutes rather, are these silicones that mix up into an elastomeric material. They have improved handling, higher dimensional stability, so they're not going to shrink, they're not going to distort as easily. We can store them for a long time. Obviously, the disadvantage would just be the cost side of things. So what we do is we take the preliminary impression before we ever start working on this tooth, and this is what we have here is an example of our alginate impression. Now to make this alginate impression work just a little bit better than what it has for us so far, I've actually started the process here, is to go around and trim off the excess material that is around the tray itself. So you can just use a pair of scissors, or these are surgical scissors, really sharp. And this just allows it to be seated that much easier back into the mouth. Another thing that will help with any kind of voids or errors with this is that if you look here, there's this extra little flag material that's from the interproximals. This can kind of impede you from getting the occlusion, biting down correctly. So what we're going to do is go in and snip out the lingual side of each of those little flags. And kind of knock them loose there. We are going to keep the buccals or the facials in simply because that's going to help create and define the anatomy of that provisional crown when we're done. So all we're doing is cutting around the excess from the outside, just cleans it up, makes it easier for us to line it back up when we're ready. And then we're trimming out this lingual extra flag material from in between the teeth here. We are going to learn how to mix a material that is used for provisionals, which involves the use of a liquid and a powder. Now we're going to be using Bosworth Trim 2. There are other brands out there. Even Trim has 1 and 2, and they come in different shades. You can mix the different ones to create more of a custom look to it. Now, what it requires for the mixing ratio is 6.3 grams of powder and 3 milliliters of the liquid. Now, if we were to mix that amount, we would have a lot of material. So we're going to mix about half a millimeter to a full millimeter of the liquid, which I've already dispensed in here. Then we're going to slowly start adding the powder and mixing it in. And we like to add the powder to the liquid to avoid any kind of air bubbles. And the consistency that we're looking for is that of honey. I think that nice sticky consistency. Right now it's still really wet. And you can see how I've got a lot of material even with using 1 milliliter, so you could use half a milliliter when you're working with just a single tooth. All right, so we're kind of at that honey consistency. This might be just a little bit thicker, but we're going to take this material once it's mixed together, and we're going to load it into the tooth that we're working on. Now you can use it with your spatula. You can pour the material directly into the tooth you're working on. And you want it filled up to the gingival margin and then a little bit into the teeth of the interproximals beside it. And that's going to help make sure there aren't any voids interproximally. Get that nice and smooth across there. This then we're going to wait for it to start looking a little bit dull. It's really shiny right now. We're going to let it set just a little bit till it's a dull shade. And then we're going to line it back up with the teeth. We're going to have the patient bite down, and for about 30 to 90 seconds it's going to be in their mouth. Now we don't want to pull this when this is still really wet. So if I put this on here, you can tell that it kind of strings a little bit. It's actually starting to dull on us, so this would be a good point to put it into their mouth. You want it to where you can cut it in half without it stringing on your instrument. And that's when you'll remove it. You want it to be in that elastic consistency so that it doesn't hold on to the tooth. You know, if it went subgingivally or interproximally, it kind of locks on there if you don't get it out soon enough. But they would line up, bite down for about 30 to 90 seconds. Then you go to remove it. If it is on the tooth, then you want to gently remove it from the interproximals with an instrument like an Explorer or a scaler. Be careful not to lift from the direct buccal or the direct lingual surfaces. Otherwise, you are going to more than likely fracture your tooth. So in review, we're working with trim, and trim is that powder and liquid where the ratio that we're going to be using is half a milliliter to a milliliter of liquid. We're going to add the powder in until it becomes a honey consistency, and then we use it just like we've been using the other material. You do want to make sure that you clean this out of your mixing container if it's not a disposable container right when you're done with it. Otherwise, it's going to set up in there and it's going to be really hard to clean out. Another example of a provisional or a temporary crown would be one that is prefabricated. You'll see this in some offices that choose not to do custom provisionals in pediatrics, or maybe we just keep it as a backup if the patient comes in and they have a fractured tooth that we wouldn't be able to use to make a custom provisional from, or maybe it is an anterior tooth where we aren't as confident in our aesthetics of the custom provisionals. Or maybe it's in the case where you forgot to take your preliminary impression at the beginning of the appointment and you have nothing to make your custom from. So this technique kind of eliminates the need of a preliminary impression. What happens is they come in containers with all kinds of different sizes and shapes. So they've got anterior teeth of different sizes and shapes. They've got premolars. And what you do is you find the size that you think is going to work best, and you try them in and out and see which one you like. You know, maybe I tried this one in to see, okay, I'm not entirely fond with that one. Let's try another one. And you can adjust them with like your hand pieces and other instruments, and then backfill them with the trim material to fill in that big gap in there so that it fits more snugly to the actual prepared tooth there. Another option for your posterior teeth are going to be your stainless steel crowns, and you'll see this being used in pediatrics a lot for their actual crowns. Instead of fabricating a porcelain or a ceramic on a posterior tooth, they'll work with these prefabricated stainless steel. These can also be trimmed with like your crown collar scissors or just simple scissors like my surgical ones here. If I think that this one's going to be too high, I can go around the edges, trim it off to where I want it. There's all that debris. And then smooth it off with some burrs, make sure there's no rough edges, and I can either backfill that with some material like trim, or I can fill it all in with that temporary crown cement, or in like a pediatric mouth, we would be using a permanent cement in that case. But we try them in. We can adjust the occlusion and see which one we like best based on the mouth itself.
As with every area of dentistry and the new technologies that are coming out, we are seeing more things change and evolve. For example, with dentures, we can have our traditional milled dentures or even 3D printed dentures. The 3D printed dentures yields a very similar aesthetic functional result, but in a vastly different way of being fabricated. Oral and maxillofacial surgery is a surgical specialty that focuses in on the reconstructive surgery of the face, facial trauma surgery, the mouth, head, neck, and jaws, along with facial plastic surgery for cleft lip and cleft palate surgeries. Through dental implants, dental alveolar surgery, temporomandibular joint, general surgery, reconstructive surgery, facial cosmetic, facial deformity, craniofacial surgery, facial skin cancer, head and neck cancer, microsurgery, facial trauma surgery, and additionally, general anesthesia and deep sedation. Obtaining their board certification through the American Board of Oral and Maxillofacial Surgery. In the US, oral and maxillofacial surgeons are actually required to undergo 5 months of intensive general anesthesia training. An additional month of pediatric anesthesia training is also required. When the specialty was just beginning in 1844, the Harvard's Medical School in Massachusetts, Dr. Horace Wells began using anesthesia but had very limited success. It wasn't until October 16th of 1846 that the Boston oral surgeon Dr. William Thomas Green Morton gave a successful demonstration using diethyl ether in one of the most important and well-documented events in American medical history. This was done along with other well-renowned surgeons in a surgical amphitheater with a live audience. They were able to remove a tumor from the neck of their patient, Edward Gilbert Abbott. In 1945, oral and maxillofacial surgeon Dr. Niels Jorgensen was first to develop intravenous moderate sedation. Utilizing pentobarbital, mepridine, he had great success. As with any, there are many specialized surgical instruments. We're going to learn some of the more common ones that you'll see a lot in like your general dentist office. And the next video is going to be quite thorough of the different surgical instruments that you can see in an oral surgeon's office. Specialty, it does require additional years of training and recognition through the extensive 4 to 6 year surgical residency. Training covers all the specialty scopes of practice. different organizations. These next few videos are going to have real patient cases. So you're going to see a sinus lift, an extraction with an immediate implant, a Lefort 1 osteotomy, and a bilateral sagittal split osteotomy, which are jaw surgeries. The Lefort 1 and the BSSO, there is a animated version of the surgery that's incorporated in the next few videos. So if you don't feel like you can watch the entirety of these surgeries, because they are quite intense and not for everybody, that's for sure. I do encourage you to try and watch through these videos so you get an idea of some of the things that can occur in an oral surgeon's office. I would strongly encourage you to jump onto your Quizlet and look over your trays that you're going to see for the final exam. We're in week 7, so we are slowly inching our way to that final exam of the course, which will be formatted very similarly to the midterm assessment, where you will have a clinical that you will set up and label a specific procedure for. You will follow infection control protocols, but there will be additional clinical skills assessed, like taking impressions and pouring up models. You'll take x-rays, you'll read and mount x-rays. You're also going to make temporary crowns, all things that we are reviewing and practicing not only in our virtual training, but also in our clinicals, which is why it is so important to continually look through your notes, watch over your virtual training, review anything that didn't make sense, and being present not only physically, but also mentally at your in-person clinicals. If you're there and you're just scrolling on your phone or you're goofing off and chit-chatting the whole time, you're only hurting yourself. Not only are you distracting and, it's not very respectful to your instructor either, to their time, but you're hurting yourself because you're going to get into an office and they're going to expect you to have a certain level of education, and you spent the time that you could have been learning and perfecting those skills scrolling on Facebook, posting to TikTok and Instagram, things that I would encourage you to just not worry about while you're in class.